Thank you very much, Mr. Chairperson, ladies and gentlemen. It is my great honor to steer this Medtronic Proctorship program. And congratulations for the static cryopulmonary vein isolation in Vietnam. I also appreciate the Medtronic for providing this wonderful symposium. This is my disclosure information. Okay, let's start from the catheter preparation. The cryoballoon ablation system is largely divided into three parts. The first one is deflectable outer sheath, as we call it FlexCat, and the cryoballoon catheter called the Arctic Front is placed inside it, and the 28 millimeter balloon is mounted on the Arctic Front tip. Then a tube catheter, a PB mapping ring catheter, is inserted into balloon catheter's inner lumen. There are two white markers on the balloon catheter shaft here and here. And when the distal marker reaches the entrance of the delivery sheath, the balloon tip is located at the distal tip of the sheath. When the proximal marker reaches the sheath entrance, the balloon proximal side is located at the tip of the sheath. When the delivery sheath is ready, we conduct transeptal puncture. Then we take an LA angiogram and test the cranial pacing. Left atrial angiogram is very, very important because cryoballoon PBI is an anatomy-dependent procedure. Take pictures of a left side PB and right side PB and the AP view. And next, our right side PB angiogram is taken at RA of 35 degrees. So we use RV pacing to shorten the diastolic period and take the better angiograms. Then we move RV catheter to SVC, subclavian vein junction, for right cranial pacing. Here, check the stable diaphragmatic capture by pacing 4 to 10 MA between the electrode 1 and 4. So this distal and the proximal pair make a wider capture. And ECG lead is attached to the right costal margin with the clavicular level to monitor compound motion action potential. We call it CMAP. When CMAP amplitude decrease more than 15%, it is a sign of right side brain nerve damages. So when you do the right side PB freezing, the brain nerve capture monitoring is very important because there is a 2% risk of right side brain nerve paralysis during cryo PB isolation. Once LA angiogram and CMAP are ready, SL1 sheath must be placed in the delivery sheath. To safely perform the sheath exchange, we insert the pigtail catheter on which the LA angiogram was taken into the left upper pulmonary vein deep inside the CT and push the sheath also deeply. Then the guide wire is inserted to the left upper pulmonary vein and exchange for the delivery sheath with outer diameter 14 French. It's quite tough sheath. Then we prepare the balloon catheter after parking the delivery sheath in LA. First, the saline flushing must be done to ensure there is no air bubble in the Arctic front. And second, a tube catheter must be inserted into Arctic front inner lumen, and the air must be removed. Because a tube catheter breaks easily, it must be manipulated gently. This is method for preparation to prevent air traffic before inserting the balloon catheter into the delivery sheath. Once the catheter is inside the sheath, you have to aspirate blood via sheath side arm to confirm no air bubble. Okay, shaking and then cover plastic, remove the air. Once balloon catheter is inserted to sheath, the console automatically test and prepare the freezing. Then we can insert the Arctic front balloon catheter inside the delivery sheath. You can deflect both sheath and the balloon catheter respectively, and you can steer the catheter by applying torque or deflection to the schist. I already told you the meaning for the two white markers on the shaft of the balloon catheter. When distal marker reaches the entrance of delivery schist, balloon tip locate to the schist tip. When proximal white marker reaches the schist entrance, balloon proximal side is located at schist tip. So at the proximal marker position, the schist tip is proximal to the portion of the balloon. Now we are ready to freeze each PVs. First, place the Arctic a chip catheter. This one is a chip catheter, right? The chip catheter dip within the target vein and place the balloon tip near the PV ostium. Then perform the contrast injection while inflating and pushing the balloon to confirm the no contrast leak. Then you can start freezing. Cryo-PBI is anatomy-dependent procedure, so I strongly recommend displaying previously taken LA angiogram on the monitor and comparing it side by side with a real-time fluoro for freezing. Two things are important at this timing. The first one is to compare the position at the same fluoro angle, AP view and RAO 35-degree view. And the second one is try to use bony structures and mapping catheter, other mapping catheters as a landmark to ensure your catheter position. So during waiting for freezing and thawing, you can estimate the next pulmonary vein location comparing to the bony structures and other catheter electrode markers. It is also very important to maintain proper alignment of a cryoballoon to create an appropriate contrast sealing. The key is to pushing the schist and catheter at a coaxial position while considering the compression angle. The appropriate nadir temperature during freezing might be -50°, and you need to remember here that the thermocouple location is at the balloon proximal location here. Because the PV cross-sectional area has an elliptical shape, no matter how manipulating the catheter is, sometimes you cannot get a good contrast sealing in some PVs. This study confirmed the effect of a short and long diameter of a pulmonary vein ostium and their ratio on balloon nadir temperature. In particular, left inferior pulmonic vein are flat and it's hard to achieve sufficient freezing. Also, the anatomy of a small pulmonary vein ostium, the nadir temperature drops less. So larger, shorter diameter achieve the lower pulmonary vein, the nadir temperature during freezing. This is because thermocouple is located at the balloon proximal side. So the proximal balloon is more exposed to blood flow warming in those small PV cases. And also because both inferior pulmonic veins are located below the transeptal puncture site, getting proper sealing with just pushing is difficult. So this reason, the delivery schist is bent at the right angle and freezing begins using the hockey stick technique. When the cryonery is sufficiently frozen, the lesion formation of the low margin is facilitated by using pull down all the delivery schist and catheter together and make a better contact to the bottom of the lower pulmonary veins. Good contact can be made with upper pulmonary vein but just by pushing, but if the contact is too good, PV stenosis and the fracture paralysis can occur. At this time, you can use proximal seal technique, which involves pull back the catheter while performing contrast injection, checking the little leakage of the contrast, and then push it again. So to avoid the risk of complication. What should we do during the 4-minute waiting time for freezing? The most key optimal freezing parameter might be time to isolation. We call it TTIA. This is to look the PV potential elimination time on the tube catheter. And if I make a long story short, a TTI of less than 75 seconds is a surrogate marker for optimal PV freezing. Remember these numbers, less than 75-second TTI. This is the outcome of ICE-T trial. If TTI less than 75 seconds, just 240 seconds, 4-minute single freeze is good enough for acceptable rhythm outcome. However, TTI is not available in sometimes because in case of deep tube catheter position, especially both inferior veins, in such cases, nadir temperature minus 50 degrees and the thawing time longer than 10 seconds could be monitored as a surrogate marker for optimal PB freezing. Because cryo-PBI has over 2% risk of right frenulum paralysis, CMAP monitoring is mandatory, and you have to check the CMAP before freezing of the right side PBs, and more than 15% reduction of the CMAP amplitude during freezing is a sign of frenulum damage. So if you watch the reduction of CMAP, you have to stop and deflate the cryoballoon as soon as possible. We call it double tap technique. And this study shows that double tap reduces the risk of a long-lasting cranial injury. And do we have to monitor CMAP during right inferior pulmonary vein freezing? The answer is yes. We experienced 2 cases of fracture damage during RI-PB ablations. So how to manage it? Let's discuss it later. Although it is rare, atrial fistula could happen after cryoablation. So I always monitor the esophageal temperature, but the safety cutoff temperature is quite variable from lab to lab. I'm using 16-degree cutoff value. That is Frankfurt group criteria. Okay, the last one is thawing. After 4-minute freezing, we stop the freezing and measure the thawing time. The thawing time longer than 10 seconds reflects optimal PV freezing. After thawing above 20 degrees, balloon deflates automatically. And some patients have slow shoulder vagal response after balloon deflation, especially left side pulmonary vein isolation. And to retract the balloon catheter inside the delivery sheath tip, you need to stretch the balloon catheter by pushing button within the transient balloon inflation, then pull back the catheter inside of delivery sheath. Okay, so finally, I would like to discuss about the appropriate indication for cryo-PBI isolation. I don't believe you can apply cryo-PBI in every single patient of atrial fibrillation. We studied this randomized clinical trial, CRAFT trial, and how different between hypersaturation PBI isolation versus cryoballoon ablation. In this CRAFT RCT, we found absolutely no difference in rhythm outcome, but even shorter procedure time with cryo than RF. However, complication rate was marginally higher in cryoballoon ablation because of a 2% risk of right frenulum paralysis. However, all those right side frenulum paralysis recovered within 2 months. But not all hypersaturation and cryo are equally effective in PV isolation patients. This study compared the RF versus cryo with propensity score matching in more than 2,100 patients. How differs cryo PBI versus RF PBI? We have reported a similar rhythm outcome between cryo versus RF. However, in patients with larger left atrial volume index over 38, cryo-PBI shows a worse rhythm outcome than RF-PBI, especially in patients without extra PV triggers. In other words, PV-dependent AFib with large LA, cryo-PBI outcome was worse than RF enteral ablation. This is comparing the enteral ablation versus cryo-PBI lesion. It may be because 28 millimeter fixed size cryoballoon spares some area in PB antrum and a large LA patient in computation modeling study. Small LA cryo PBI completely isolated the antrum, but large PBI, there is some entra sparing. Okay, these are tips for effective and safe cryo PBI isolation. Number one, careful observation for PB anatomy using the CT or LA angiogram. Number two, ensure the achieved catheter is leading the system manipulation. Number three, maintain manual pressure until cryoadhesion, about 30 seconds. Number four, watch your diaphragmatic CMAP and esophageal temperature. Number four, proximal seal technique to prevent overfreezing and the potential complication. And be prepared for the vagal response. And lastly, segment approach if unable to obtain full occlusion. Okay, thank you very much for your attention. I'm happy to accept your question and discussion. Thank you.